So we presented a case of a gentleman with very high-risk localized prostate cancer. He was deciding between undergoing surgery or some form of radiation with hormonal therapy. Many men up front are not interested in having hormonal therapy unnecessary. The challenge is with surgery, we know that for many men, the surgery will not be enough and they will need to go on and get additional treatment. The challenge is identifying who those men are up front so that we could add or intensify treatment to make the results from surgery better. So we are part of a multinational clinical trial looking at a variety of agents, mostly around hormonal therapy, including apalutamide, which is an ARSI, and niraparib. It is a genomically driven trial, so one of the biggest limitations we've had, again, is characterizing these tumors and identifying which men may respond to specific agents and adding that up front to improve the response from surgery. Yeah, I'm going to start with the second part of that question. The tools we're missing are biomarkers to understand who needs more treatment and who can safely have less treatment. There is increasing demand, I would say, for precision medicine in not treating everyone the same way, meaning identifying characteristics of an individual patient that will help us tailor their treatment, either more treatment or less treatment. As there's a lot of interest and concern for men with prostate cancer, I think a lot of men don't undergo screening for prostate cancer because of their concern of the side effects from treatment. So to answer the first part of your question, I find it equally challenging on deciding when to de-intensify just as much as when to intensify because of the fact that we don't necessarily have the precise tools yet to identify which man will benefit from more treatment and who safely can have less. Yeah, that's a great question, and I agree. Multidisciplinary tumor boards need to have a variety of physicians, advocates, research coordinators on these tumor boards to be able to give a fair assessment and advice. If I understand the question correctly, the best way to make it more accessible, I think, is nowadays leveraging technology and allowing smaller hospitals and more rural hospitals to call in and actually present cases and present the tumor board without actually seeing the patient. So they often get advice and they can get a variety of opinions in one very efficient setting. I work at UC Davis in Sacramento Hospital. We have a large population, a large city, but also Northern California has rural cities as well that don't have access to all this subspecialized care. So we do have what's called a cancer care network where we collaborate with smaller hospitals. Everyone can get online nowadays and utilize Zoom to zoom into our tumor boards and present cases and have access to a different level of expertise.